Well, good afternoon to you all, friends. And first of all, let me congratulate Financial Express for organizing this very, very topical, seminar, workshop, whatever you call it. And I was there in the last session, and just for a few minutes, and I heard words like digitization, machine readability, interoperability. These are very, very important and powerful words. And I would probably like to kind of speak about these issues largely as to what the Ayushman Bharat Digital Mission is seeking to do, seeking to achieve. It's a very, very audacious mission to digitize the entire healthcare industry in India. And obviously, this mission will not succeed unless all the stakeholders participate actively into this. What the government can do, government can create a framework, can lay down the roadmap, can probably create digital public goods to essentially for everybody to share. But ultimately, all the activities will have to be done by the service providers, by the hospitals, by the laboratory. I see Dr. Lal sitting here. They are the ones who will have to actually actively participate in it. And when we talk about digitization, digitization is understood in many facets, For example, if you scan a handwritten document, that also is understood as a digitization, as a digital document. Yes, it is digital because the composition of the document is in bits and bytes. To that extent, it is digital. But actually, it is highly non-digital because it cannot be read by a machine. So essentially, there are classifications of digitization which start from a handwritten document, a scanned document, then of course typewritten document which can be OCR'd, and finally a document which is machine readable. So machine readable is the highest class. If you call them, class 0 to class 5, machine readable document is the highest class document, class 5 document. And what we want to do is really to create machine readable documents which can be interchanged or travel from one destination to another destination. So that's what exactly will be the ideal state of digitization, which is not happening as of now. Of course, the laboratories, for example, when you do a blood test, they will issue a PDF document to you, which you can, sort of store it, and then of course you can scan it and you can do whatever. But that PDF document is not a machine readable document. So essential idea is to use that part. Now, what does really Ayushman Bharat Digital Mission, about which I want to share some thoughts with you, what does it intend to do? What is the objective function of this particular mission? The objective function of this mission is to essentially leverage the information and communication technologies so as to make healthcare provisioning affordable, ubiquitous, and quality oriented. That's the broad objective. And ultimately, it is not as if the digital systems will provide the services. Digital systems always are enablers. Ultimately, services will have to be provided by the doctors, by the laboratories, by the pharmacies, and all these ecosystem partners. But digital will essentially enable it, make it more cost effective. For example, if you can have a video consultation with your doctor, then your travel cost and all kinds of costs are saved, and therefore it becomes much more affordable. It becomes ubiquitous because then a person sitting in remote rural area can communicate with the doctor in a specialty center. That's why it becomes ubiquitous. The reach increases. So essentially, technology is an enabler to make things better, simple, etc. Number one. Number two, the objective is to ensure the empowerment of the patient. The patient should become empowered. So how can we have a patient-centric digital system evolved so that patient has control on his or her own data? She or he can transmit data, can share the data after giving her consent. So these are some of the overarching goals. Now, what is this system, or what is the framework which we are creating under the Ayushman Bharat Digital Mission? So the one component, and these are basically components or the building blocks of this entire architecture. So the first component is the ABHA, Ayushman Bharat Health Account. So in a way, what we are doing is we are opening Ayushman Bharat Health Account like a bank account for each individual. The idea is like you keep the money in your bank account, now you keep the digital records or the records, let's not call them digital, the health records of yours, your diagnostic reports, your discharge summaries if you have had hospitalization, your prescriptions, etc. This is what you keep in that ABHA account. So that basically becomes a receptacle for your documents. The question is, it is not that once you create ABHA account, then there is a central bank which keeps all the accounts, from everywhere. No. We have what is called a federated architecture. Somebody here spoke about consolidating all the documents. That's not the objective, because that will mean that there is a central repository of all health records of everybody, and then of course people will talk about surveillance, people will talk about violation of privacy and other kinds of things. It will also become a single hacking point where hackers will be able to hack, then everybody's data is gone. So therefore, what is really required, what we believe in, is a federated architecture, which means we are simply linking the health record to a person's account, and that link is provided, a link is what is kept at a central place, not really the actual document. Which means if I visited Apollo, then my documents are still with Apollo. I am only providing a link to that document so that they are accessible by me as a patient. Health account is there because I have a full control on that account. I can, like in a bank account, I am the one who can actually, control the debits and the credits to that account. Similarly, a health account is there where I have the control to access the document. So this is the health account. Then the question is that, in the system which we are providing, there has to be a sense of registry, because ultimately we need to know who are the authorized medical practitioners for each branch of medicine. So we have the health providers registry. That's what we are trying to construct based on the, whatever degree you have got, so that we can avoid quacks into the system. Currently, everybody who makes a solution basically makes, onboards the doctors on the solution. Think of Practo. Practo is one of the digital solutions for healthcare provisioning. What they do, they onboard doctors on their platform, then they onboard some pharmacies on their platform for supply of, drugs and other things. Then they basically onboard patients on their platform, which means that they give the application also is in the hands of everybody. So currently the application providers are actually building a vertical structure which has got doctors, patients, pharmacies, etc. What we are saying, you don't need to really onboard the doctors, because each person spends a lot of money in verifying the credentials of a doctor. What if the country itself provides as a digital public good the list of doctors? So this is the concept of registries. So we are making a registry of service providers, the hospitals and facilities, making a registry of laboratories, making a registry on the other hand of doctors. These registries can be used as a single source of authentic truth, which is validated by the government. So this is the government's contribution. One is creation of ABHA account and maintaining those accounts, creating a consent management framework whereby a patient is able to access his or her own records and can share these records with the doctors. So these are some of the digital, public goods which we are constructing. Then we also want to promote insurance industry. Currently, what is happening is health insurance coverage is not given for OPDs. It's only given for certain serious diseases. Why? Because the cost of processing an insurance claim, I am told by the experts, is of the order of 400 to 500 rupees per claim. Now if my total bill is 500 rupees and if I spend 500 rupees on its processing, what is the point? I mean, you can't have a viable insurance part of thing. So we are creating a health claims exchange. And what we are doing is we are actually standardizing the entire, people talked of SNOMED CT, then of course LOINC, and then CHAI and other kinds of systems. We are, maintaining, we are actually managing the FHIR, fast health interoperable resources. That's the construct which we are making, and we are making a pipeline, the health claims exchange, which will be able to, standardize the claim submission process, standardize the claim, payment process, and make the entire value chain absolutely transparent. So that's another part. The last but not the least important is what we call the unified health interface. Now, what is unified health interface? You see, UPI, Unified Payment Interface, which all of you must be using, Google Pay, Phone Pay, Paytm, etc. That actually unbundled the banks from the payment system. Initially you had the SBI's application, ICI's application, and if you were doing transactions, you have to have the application of that bank. What UPI did was, UPI created a protocol and unbundled the payment from the banks. So now you have, payment providers, which is the Google Pay, for example. Google Pay doesn't have a bank. But then they are able to do transactions from one bank to another, one person to another person. And that happens because there is a protocol which makes it interoperable. Two more examples of interoperability which you are quite familiar with. One is telecom. In a telecom network, if I am on Airtel and you are on Vodafone, no problems. I don't even have to think on what other phone provider you are on. I can straight away make a call. And a call initiated by Airtel has got to be fulfilled by Vodafone in their lag. This is interoperability. Similarly, if I tell you, if I send a mail to you, if I am on Gmail and you are on Rediff Mail, I can send that mail to you. That's interoperability. That basically interoperability is there because there is an underlying protocol which actually defines the way things must be interchanged. So for example, for mail, you have what is called the SMTP protocol, Single Mail Transfer Protocol. On other things also, there are protocols. So essentially what we are doing, UHI, Unified Health Interface, we are making a protocol-driven, system and interoperable architecture. So once you have that kind of architecture, then you don't have to integrate peer-to-peer. You basically follow those protocols and you are good to go. So if I open a mail system and if I follow the SMTP protocol, I don't have to tie up individually with individual mail providers. This is the concept and construct of UHI. So that means that you can be on, let's say, Arogya Setu. Arogya Setu as a client app, I can search for doctors, and the doctors can be on Practo or some other application. I should be able to search, and they should be able to respond that they are available, which means we are making all the patients available to all the doctors, irrespective of whatever platform they may be on. Which means that if I want to, fix a teleconsultation with a doctor, I don't have to be on the same application on which the doctor is. Doctor can be on, let's say, in the normal communication, doctor can be on Zoom, and I can be on WebEx, and still we can communicate. I mean, I'm just giving an example, not that Zoom and WebEx are going to communicate. So this is the interoperability which we are bringing about, which we believe will open up the market many fold, and which will truly, because I don't have to have 20 applications now. I just have to have one application and I'm connected with every other application on the same subject, provided every application, all those applications are following that UHI protocol. We have published the protocol, we have published the market rules for these protocols, and I think now things are going to happen. I'm happy to say that at least 12 players, existing players, Briefcase, Eka, Care, I don't remember the names,
they have actually integrated, they have actually become compliant with the UHI protocol. So that's the way we are progressing. So what I feel is that we are quite different and unique in the whole world in the way we are actually creating the framework. This framework is actually combines the best of both worlds. One, governments are good at creating the framework and standards and interoperability part protocols, which we have done. But we don't want to restrict the innovations which the private players can do. We are not innovators. We can just create frameworks, but I think innovation lies in the startups, in the young boys and girls. They can do innovation. So what is happening is now in the teleconsultation application, in the pharmacy delivery applications, in everything, they are the ones who are creating innovation. So we allow innovations to happen around the ecosystem which has been built. And that ecosystem is interoperable from the word go. It basically reduces the entry cost because now you don't have to do a verification of various kinds, similar to what Aadhaar has reduced the electronic KYC cost. Why did this jam happen? When Aadhaar was not there, and Aadhaar did not have those services of the electronic KYC and other things, bankers, I've been in this administrative job for about 45 years now. When, we used to say to the bankers that open a bank account, bhai kisi ka bank account kholo aap. Bole sahab, iske paas ye kagaz nahi hai, wo kagaz nahi, that is one part. Secondly, they will say कि साहब ये अकाउंट खुलवाना नहीं चाहता. अच्छा, खुलवाना नहीं चाहता ऐसी बात नहीं थी. बैंक वाले खोलना इसलिए नहीं चाहते थे कि अकाउंट खोलने की कॉस्ट करीब 100-150 रुपया होती थी उस समय. आप पेपर लाइए, फिर पेपर की फोटोकॉपी कराइए, तो उसको अटेस्ट कराइए. तो इस तरह से द डॉक्यूमेंटेशन इटसेल्फ वाज वेरी लार्ज, वेरी कॉस्टली. और वो आदमी 150 रुपये का कॉस्ट करा के इफ ही डिपॉजिट्स 50 रुपीज इन हिज अकाउंट, why should a bank wala do that? It doesn't make any sense to him. Now, once electronic KYC of Aadhaar came, the cost came down to 1 rupee, 2 rupee, even free. In fact, it's only now that the Aadhaar has created 2 rupees or something. Otherwise, it was free. And therefore, 490 million accounts were opened using Aadhaar's electronic KYC. Now you can open an account sitting at home. So basic idea is, if you bring down the transaction cost, things happen, things accelerate. And now you have about 82% of adult Indians have got a bank account. This figure actually is comparable to even Switzerland and all those developed countries. This is what we have achieved in digital public infrastructure, digital public goods. So I think that's the vision. What we are beginning at a cleaner slate. We are beginning with a very, very robust architecture, and we have proven architectural, clarity and conceptual clarity, which we have done Aadhaar or UPI or many other artifacts. You may be aware that Aadhaar has done 71 billion authentications. 71 billion, 7,100 crore authentications. There are only 130 crore people in this country, so you can imagine everybody has done, on an average, 70 authentications in the about 8 or 9 years of Aadhaar. So India is highly digital, digitally, we are extremely, extremely agile. We are extremely, CoWIN, for example. I don't think any country in the world has got that kind of digital backbone which actually manage the vaccination program in this country. 220 crore vaccination jabs are recorded on CoWIN, and today you can just go on CoWIN, enter your mobile number, do the OTP, and you can get the certificate of all your family members. So this is how we are constructing. Through this place or through this audience, I would like to encourage everybody that please help, in digitization process. I'm very happy to share with you that we have created 320 million Ayushman Bharat Health account, 32 crore. We have linked 11 crore health records with these accounts. Very small things, you know. There's one concept which we came up with. Everybody was asking, what is the use of this Ayushman Bharat? What is the use of this Abha ID, etc.? What we did was, there are lines in the All India Institute of Medical Science, you know. When you go there, 4 बजे से लोग लगते हैं उसमें, सवेरे 12 बजे तक लगे रहते हैं, 8 घंटा, उसके बाद भी नंबर नहीं आता तो चले जाते हैं, फिर दोबारा लगते हैं दूसरे दिन. What we did was, we simply said, put QR codes. Everybody is familiar with QR codes in this country. You know, people are paying Paytm, fellow, Chela wala, Ready wala through QR code, 20 rupees, 30 rupees. So we said, put up QR codes. You go and scan those QR code. You are given a token number. You sit with that token number. And straight away, when your token number comes, you just go there and you can get your OPD card printed. You don't have to don't have to be in the line. Simple. Now, this, what it does, the QR code scanning transfers your personal information, personal profile, which is RS Sharma M67, that kind of thing, which is what you require on your OPD card. It goes there, and the token number is given you. When you go there, the token number is entered, and immediately you can print your OPD card. In fact, we can probably tomorrow provide a system where there are kiosks where you scan the QR code and the OPD card comes out as you print the, nowadays boarding pass for your travel. Simple. And you'll be happy to know that within 50 or 60 days of its launch, we have done about 200,000. 2 lakh लोगों ने इसका already फायदा उठा लिया. You can go onto the dashboard.abdm.gov.in, where you can see all the real-time statistics on this. So essentially, I see it as an extremely good future for digitization of the healthcare in this country. This country has shown agility. This country has shown a scale. This country has shown that we can achieve things and we can really bring about frugal economy in this part. You know, when the England's ID card was made, it was said that it will cost 135 British pounds for each card. We created one card for £1. The total spend was 7,000 crores for 100 crores cards. 7,000 crore rupees, which is about 70 rupees per card. And that includes the cost of technology, cost of creating the card, cost of enrollment, cost of printing, cost of giving the card to the persons. So we have done scalable, frugal, interoperable, standard-based, open API-based, open source-based technology development. And I think what is needed by all these stakeholders is to actually latch onto this bandwagon and create history in the world that yes, India can do it. Thank you very much.
So we can take some questions if anyone has some questions from sir.
Myself, Dr. Hakikat. I have just graduated after doing my MBBS last year and currently doing my post-graduation in computer science and AI. My question to you is that what was the thought process or the logic behind having multiple health IDs linked to a single person or a health account, if it's so?
No, I think your question seems to be not really multiple health IDs, but multiple IDs to a person.
Yes,
right?
sir.
So let me answer this question, and I think it's a very important question. Many people say कि जब आपने आधार बना दिया तो फिर बाकी किसी की ज़रूरत क्या है? I think Aadhaar should work for everything. Now there is a let me conceptually clarify what was Aadhaar. Aadhaar is the world's first identity, which is a foundational identity, not a functional identity. And let me say what is the difference. The difference is Aadhaar says that this is Arvind Lal, right? It doesn't say anything more or less about him, whether he is the owner of Lal Path Lab or whether he is a PhD or whether he is MBBS, nothing. So essentially, Aadhaar is an individual's identity bereft of any eligibility. So much so that Aadhaar did not include even citizenship. You know, it's not as if R.S. Sharma has an Aadhaar, then R.S. Sharma is an Indian citizen. No. In fact, if you have received Aadhaar number letter, then it says Aadhaar is a proof of identity, not of citizenship. So Aadhaar is just proves minimal, it has minimal information. What information? Basically name, father's name if you have given it, or otherwise guardian's name. Then of course gender, and then date of birth. And then communication address, which is actually changeable, so that's not. So essential identity ingredients are Aadhaar. However, your driving license is actually a document of eligibility that you are authorized to drive. Your passport is a document of citizenship. Your voter ID card is your eligibility that you are authorized to vote, right? So essentially these are, and they, because Aadhaar is a fundamental identity, that actually is underlying against in all the other identity documents. Driving license, yes. Who is the driver? Who is that person? So who answers, the Aadhaar answers that who question. But what eligibility this person has got, those other identities have to answer. So therefore you cannot, you cannot combine everything. For example, I can be, let's say, I can be a government servant. And if I just have Aadhaar, my government servantship can be, rescinded, or I can be thrown out of the government. But Aadhaar is actually an identity which is immutable. So much so that Aadhaar does not die with your death. That number is never allocated to anybody. And we have got 100 billion numbers. If you see 12-digit Aadhaar has got 11 digits significant, and 1 digit is last digit, which is a check digit. 11 digit can construct 10 to the power 11, which is 100 billion numbers. And in that 100 billion number line, we are only 1.3 billion, which means if you guess a 12-digit random number, the probability that it is somebody's Aadhaar is only 1%. So it's a random number. So essentially, you have to have different identities for different functional needs of yours. That is why you can't have identity Aadhaar as the only. Of course, they should be linked to Aadhaar so as to ensure uniqueness, so as to ensure existence, that this really belongs to somebody. That's the difference.
So
I hope I have answered your.
Actually, my question was that if the same person is going to different labs or different hospitals, they can make a fresh ID altogether. And if the patient is sharing data with a physician, I'm talking as a physician, that if patient shares data with me, I'll be just able to see a part of his medical history that way, I guess.
No, I think I explained that architecture to you, that you don't have to, you shall be able to get or to see all the history of the patient, provided all the history of the patient is linked to his Ayushman Bharat health account. And that's where the whole architecture which I explained to you comes into play.
So,
I'm sorry, I gave a very long-winded answer to differentiate as to why Aadhaar can't be used as ABHA.
sir, good evening. I'm Nitish. Sir. And I'm working with Eternal Hospital. Eternal Hospital is like a JCI accredited hospital in Jaipur, and we have 3 units, sir. So basically we deal in heart transplantation and heart patient and stroke. So a couple of days back, I was having one question, why could Aadhaar card be linked with health record? In a similar manner, it is linked with our bank account. Why I was thinking that? Because couple of days back there was patient in emergency and he was having heart attack, and doctor was trying to understand what is his previous record and if there is any allergy. So I was just thinking that if doctor can have all records online, then it will be very easy. Even without telling the patient, doctor will understand everything. So you mentioned that UHID protocol and interoperability. So as per my understanding, if patient has a heart attack, paralysis, or patient is in emergency, if patient cannot speak, then even without discussing with the patient and patient attendant, doctor will understand what was his previous record, any allergy. So it will be very easy for patient. And patient will get the right treatment without any further delay. So that's the one thing, sir. The second thing is that, of course, if we have a medical record on our mobile device, so it will be very easy. People may forget their spouse, but they have their mobile phone in their hand, so they will have everything in their hand. That's the second thing. The third is like, as per JCI, this 65% sentinel events are due to communication failure between departments. So, when we are having all the reports online, then doctor and department can see all these reports, and there should not be any communication failure, sir. And third, like many times before giving approval for cashless treatment, and you rightly mentioned that the insurance company says that manipulation has been done in some part of past history by hospital or patient himself. So, if reports are available online, then it will be very easy for insurance company. It will be easy for patient, and there will not be any, doubt. So that I want to say, sir.
Doctor साहब आपने बिल्कुल सही कहा. We are also trying exactly the same thing to digitize the entire health record systems and other kinds of treatment systems, the insurance payment systems, pre-authorization, bill submission systems. Everything is sought to be digitized, and once it is digital, then it is easily transferable. That's one part. With regard to the second question which you had asked about a doctor seeing a patient's part, it's like this, that there is a break the glass kind of situation where you patient who is not in a condition to provide consent, that condition can be deemed to have been given in an emergency situation. So that is a part of the digital infrastructure which we are creating. And other parts, I think you have merely substantiated what we are trying to do and what we are trying to achieve. And I'm very sure, you see, the adoption of technology in this country is extremely, extremely good. You provide the tool in the people's hand, they start using it. They are making payments. The fact that 7 billion payments were done last month on UPI is a testimony to the fact that everybody is making digital payments, very, very small payments, even 5 rupee payment, 10 rupees payment. People are doing it. So essentially the idea is that we have learned technology. We are very good at mobile technology. There are 1 billion connections. There are 700 million, 800 million internet connections. There are 600 million mobile phones. So I think we are in a very good situation as far as the basic connectivity is concerned. And smartphones are concerned, and smartphones are capable of storing all the patient's records and data, and it should be possible for people. And today we have beautiful applications which can actually not only read your reports, which can also provide you some graphical, sort of saying that this is the way your HB1AC is increasing, this is the way your blood pressure is getting worse and worse. These are the kinds of things. Tomorrow also the wearables, they also emit a lot of data, digital data. That data should also be able to be permeated and transported through this entire digital system. It should be possible.
From our side, give us a chance from us to ask him one important question actually. In fact, it's not a question also. I must say, to the credit of Ayushman Bharat, that you have incredible reports on your site. Your own investigation studies, in fact many of them self-critical also, which is very impressive actually. In fact, I just wanted to ask you this and I'll conclude with that, is there is a lot of studies on your site, which papers which talk of utilization, the income profile of the people. Your comments on, say for example, I'll give you one statistic, that 8 to 9% of the total claims are less than, are beyond 1 lakh. So most of them are actually small. So the ticket size is actually a lot of money spent on small claims actually. And also in terms of utilization actually, most of the southern states are major beneficiaries also. How do you look at that actually? I'm just asking this as one of the things, several papers actually had pointed that out. Anything on the utilization and on the ticket size?
देखिए, ये तो प्रश्न आउट ऑफ सिलेबस है. आपने मुझे डिजिटल के लिए बुलाया था, अब आप आयुष्मान भारत के बारे में पूछ रहे हैं, पीएमजे के बारे में पूछ रहे हैं, राइट? हाँ, प्रधानमंत्री जन आरोग्य योजना, which is of course also digital in some sense, because that actually we process digitally the 40,000 hospital admissions per day, we actually process 1.2 million claims a month, and it's all digital. So that way it is correct. But with regard to the fact that the southern states are using more funds and northern states are using less funds, I really can't answer that question, because ultimately it is the states who are implementing this scheme at the ground level. They have to do that. You are very right that the claim size varies, and Ayushman Bharat does not do the OPD reimbursement. It does only the inpatient reimbursement. And the claim size is of the order of about 10,000 rupees per inpatient hospitalization. That's an average claim size.
Thank you so much. The reason I brought it out was essentially I didn't have to look elsewhere. I mean, it was on your site, which actually one could read, which was creditable actually, very nice. So thank you so much.
Let me give you a website address also. It's called dashboard.abdm.gov.in. Look at that, and you will find entire statistics, real time, how many ABHA generated, how many records linked, how many scan and share took place. Similarly, Ayushman Bharat dashboard.abpmjy.gov.in will give you the cards, the claims pending, the CGHS claims pending. You can actually go down to patient level to see as to which claim is pending. So we have probably gone overboard with a view to the transparency, but my personal belief is that transparency actually is the best antidote against corruption and against the, for example, COVID whether it was a VVIP or whether it was a common man, we were all looking at the same screen. कौन सी जगह available है, कौन सा hospital में इंजेक्शन लगेगा, मुझे कोवैक्सीन लगवाना है, मैं कहाँ लगवा सकता हूँ, कब बुक करा सकता हूँ. There was nothing called back end पे कुछ नहीं हो रहा था वहाँ पे. So this is the transparency brings about that kind of democratic, sort of, because if you remove the asymmetry of information, that is transparency. And that actually clears a lot of these things. So there is no VVIP, there is no VIP, there is no ordinary person. Everybody is the same person.
In fact, today, Dr. Soumya Swaminathan also pointed out to CoWIN, and she said this was perhaps the only platform which actually connected to 1 billion people plus, which was significant. Anyway, that's a very nice note to end on. Thank you so much, Dr. Sharma, and thank you, audience, for sparing your time.